Thank you. And just a note, this recording will be put up on YouTube with a link sent out usually within by early next week at the latest for folks that are not able to attend or would like to review the recording. TBW may also be streaming this and archiving it for additional viewing opportunities. You can find the agenda for today's meeting on the first page under tab 1 in the meeting packet. And we have quite a full agenda today, so I will hand it off to Michelle Needham, our interim chair, to call the meeting to order.
Thank you, Ross. Calling the meeting of October 23 for the Healthcare Cost Transparency Board to order. I'm trying to go a little bit slow because I see we still don't have a lot of members joining. So we don't want to jump right into roll call just yet. And I just lost my webinar. There's Jane. Okay. We're just getting started. So I appreciate everyone joining for this productive and meaningful meeting that we have planned for the day. We have a pretty extensive agenda, as Ross just noted. Thank you for planning to spend an extra hour with us today. If it takes that long, it may be that we can move through more efficiently. So we do have a main focus for today on some additional market oversight tools with a discussion around a corporate practice of medicine law, a draft bill or a bill in Washington State, as well as the law that was passed in Oregon. So we'll have some good discussions around different oversight tools that we think the board will be interested in today, as well as a brief discussion on the draft legislative report to get that started. That is open for public comments, feedback until November 3rd. So we're just starting that conversation today. And then looking ahead into the 2026 schedule as well. So that's what we have planned for today, as well as some oversight, some feedback from all of the advisory committees, the Primary Care Advisory Committee and the Nominating Advisory Committee, brief updates from the 2 other stakeholder and data advisory committee meetings as well. So we'll have, again, quite a bit of material to walk through today. With that, I'm trying to pause, Ross. I still not see very many names for you to start roll call, but I know it's you're teed up to do that. So go ahead.
Sure, thank you. And I guess just to give folks one more minute, we'll also be doing a quick review of our draft cost board legislative report. The draft version was included in the packets, and we'll be giving a brief overview later in the meeting, but just noting, would love any feedback that folks have, and certainly open to any written comments that folks have on that, and we would be grateful for those. And I will now turn to roll call. If you, when I call your name, please say here. Jane Byer, here. Eileen Cody.
She is here. Sorry, here. I thought
Here. Okay, I saw you. Thank you, Eileen. Lois Cook.
Here.
Thank you. Bianca Frogner.
Here.
Thank you, Bianca. Ken Gardner.
Here.
Thank you, Ken. Jody Joyce. Jody Joyce.
Yes, I'm here. Thank you.
Thank you, Jody. Greg Marchand. Greg Marchand. Thank you. Sorry, I feel like the Bueller every time I do that. Apologies. Mark Gregg is absent. Mark Siegel. Mark Siegel. All right, I'll note Mark is absent. Margaret Stanley.
Here.
Thank you, Margaret. I know Ingrid is not here today, and she named Leah Hole-Marshall as her delegate. Leah, are you here?
Then Leah, the right. Let's double check.
Okay, I will come back to Leah, just noting that Ingrid let us know she would not make it today and designated Leah Hole-Marshall as her delegate.
I'm here and I've been promoted now. Thank you.
Thank you, Leah. Kim Wallace. Let us know she would not be here today. And Carol.
Here.
Thank you. We have a quorum for today. So I will now hand it over to Michelle for review of the July meeting minutes to vote and approve.
Thank you, Ross. You have in your books, I believe it's tab 2 with the July meeting minutes. Is there any discussion of these meeting minutes? Seeing none, is there a nomination to accept the meeting minutes?
So moved.
Okay, I heard a first and a second. All in favor, say aye.
Aye.
Aye. Aye.
Any opposed? Hearing none, minutes are approved. Thank you. All right, Ross, I think we can kick it back to you to start public comment. I know we're 4 minutes ahead of when we publish, but I'll kick it over to you.
Thank you, Michelle. Yes, we are a little early. Just noting that folks are available to submit public comment to us at any time. Typically, we try and circulate the packet a week in advance. So written comments received a week in advance, we're able to include in the packet. But if your comment does come in late, happy to have you speak to that at the meeting. So if there's any folks that would like to speak today, please just raise your hand. Written public comments received since the last meeting can be found under tab 3 in your meeting packet. And as I noted, folks that sign up will be the first to call on. And then if you raise your hand, we will call on you next. We will have a timer up on the screen as we have a pretty full agenda today. And once we exceed that time, we can remind you to wrap up your comments. And lastly, when called upon, if you could please state your name and affiliation, that would be greatly appreciated. Sorry, one last comment. Please accept the invitation when you raise your hand to become a panelist, as this is what allows you to unmute yourself and turn on your camera. And with that, I will. Okay, perfect. Well, and I was just going to check. I know WISMA had provided a public comment in writing and wanted to give them an opportunity if they wanted to speak today. Okay, not hearing anything, then that was the only written comment we received. So now we'll turn to hands, and I believe who was the first noted? Katerina LaMarche. Yes, please go ahead, Katerina.
Hi, thank you. Katerina LaMarche, Policy Director at the Washington State Hospital Association, providing comment to you again. We appreciate the opportunity to review the draft legislative report. We'll be submitting a written response that addresses that in its entirety, but wanted to briefly comment on the portion related to private equity in the statement. Specifically, that is of April 2025, 9.9% of Washington's private hospitals are owned by private equity. That isn't technically correct, but nevertheless, wanted to note that it overstates the representation of private equity-owned hospital ownership in the state and doesn't provide the full picture. And the source cited in the report lists 7 hospitals, 2 rehab, 2 psych, 1 long-term care, and only 2 acute care hospitals as being owned by PE. And acute care hospitals are what most people think of when they think of a community hospital. I recognize that 9.9 sounds like a lot, but what's important to consider is the number of beds that represents. So when you're looking at the state as a whole across all hospital and ownership types, including acute care, psych, and rehab, there's about 14,430 licensed beds. 77% of those are private nonprofit and 15.7% are government or public. Of those 14,430, only 439 of those are owned by private equity, or about 1.5% of all beds in the state. So if you exclude government and public beds and narrow to private licensed beds, like the report's cited source, the percentage of PE beds is still just 3.6%. And then if you narrow private hospitals even further, of those 439 PE-owned licensed beds, only 206 are acute care hospital beds, or 1.8% of total private acute care beds. And there's only 2 acute care hospitals that are owned by PE in the state. which were both actually previously failing independent hospitals in rural areas that were purchased before 2020 and have remained in their communities. And they're also the only for-profit acute care hospitals in the state. Also want to note that Kaiser Family Foundation, as of 2023, ranked Washington 44th lowest for-profit ownership. So just in really brief summary, wanted to know that for-profit and private equity ownership really just isn't a factor in hospital costs, specifically to hospitals in Washington state. Most of those drivers are really due to cost for labor and drugs and supplies. So we really appreciate the opportunity to share. We appreciate the concerns in the report, but want to emphasize the importance of understanding the broader context of hospital ownership. Thank you.
Thank you, Kat. Appreciate that, and look forward to receiving your public comment or written comment. I apologize. I saw Renee Fullerton had a hand up as well.
Yes, thank you. Hello, everyone. I'm Renee Fullerton. I have the pleasure of serving as staff to the Health Workforce Council. I'm here today because I appreciated seeing in the primary care subgroup's recommendations acknowledgement of the work of the Health Workforce Council. But I thought it helpful to update you all on what we're anticipating coming from the council this year. The majority of our work this year has focused on rural workforce development, and in particular focusing on K-12 youth pathways, with the goal of educating students in place and creating opportunity in our rural communities. We also spent some time on rural oral health workforce, but we don't have anything specific coming regarding primary care. We do potentially have rural primary care development on our conversational plan for 2026. However, I just wanted to call to your attention, and I'm sure you appreciate this, that our primary care workforce challenges are very complex, and they include both the educational sort of output challenge, training the providers we need and getting them to the places where we need them, but also retention of our existing workforce, which is also under extreme challenge. And this important conversation might benefit from sort of a larger group of folks being invested and involved, perhaps similar to what's been taking place within our behavioral health sector here within the state. So thank you for your time and attention. I appreciate it.
Thank you so much, Renee. Do we have any other hands? Great. Jim, please go ahead and unmute yourself. Thank you.
Good afternoon. I'm Jim Freeberg, Executive Director of the Patient Coalition of Washington, which unites 17 of the state's leading patient groups to have one voice for better healthcare. I'm here to offer some comments ahead of your discussion later on the corporate practice of medicine. I know you're all well aware of the massive premium increases that are hitting people's pocketbooks right now. And for many people, these increases will hurt regardless of congressional action or inaction. When moments like this occur, the public expects a response from our leaders. While we can't control what happens in the other Washington, we can take strong actions here at the state level. With higher premiums, we know more people will go without care, and that's unacceptable. We need to lean harder and faster into solutions. As you learn more about the proposal to regulate the corporate practice of medicine, I hope you'll find that it's a smart move. Patients have enough of a challenge today navigating our incredibly complex healthcare system, and an increase in private equity has not been shown to benefit patients. One study showed that costs increased by as much as 32% for payers and patients after private equity enters the equation. That study also found mixed to harmful effects on quality and inconclusive impacts on outcomes. In short, the only winners here are investors, not patients. Please keep up the good work and lean into solutions like the corporate practice of medicine legislation. Patients need relief now. Thank you.
Thank you so much, Jim. I see Nancy Connolly. Please unmute yourself and go ahead.
Hi, thank you so much for hearing my comment. My name is Dr. Nancy Connolly. I'm a primary care doctor here in the state of Washington for almost 20 years with experience in administration as well as health policy. I am a delegate from King County Medical Society to the Washington State Medical Association. And in that capacity, co-introduced a resolution to WSMA, which was subsequently passed, which supported regulating the corporate practice of medicine, very much in support of Senator Robinson's 5387 from the last legislative session. And in principle, because we observe that private equity ownership of physician practices, urgent care centers, hospitals, hospice services, and laboratories is growing in our state. Research links this trend to higher patient charges, reduced staffing, and lower quality of care. Profit-driven ownership can further erode physician autonomy, fuel burnout, and shift the focus from patients to profits. So the new WSMA resolution, which was passed at this last session, calls for transparency, oversight, and safeguards to keep medicine patient-centered. On a more personal note, we know that when healthcare systems are primarily driven by profit, the quality of care that patients receive goes down. We also know that when costs are trimmed, support staff and services are often cut, which further erodes the doctor's ability to spend uninterrupted, high-quality time and attention with their patients. Finally, I've heard from doctors on the ground that when labs, specifically pathology labs, trim costs, the quality can suffer. One specific example where consolidation occurred, specimens were delayed getting to the pathology, which caused undiagnosable tissues to be received, which is of course irreversible. Specifically, there was a uterus received that was undiagnosable. Of course, this can't be redeemed once this happens. And when profits are involved, staff is trimmed. Consolidation happens, it's worse for patients. I appreciate your taking my comment. Thank you so much.
Thank you so much, Nancy. Michael, I believe you're next. Please go ahead and unmute yourself.
Thank you for the opportunity to comment. My name is Michael Fenney. I'm with the Private Equity Stakeholder Project, a nonprofit that researches the impact of private equity ownership across industries, including healthcare. The state of Washington is highly exposed to private equity, according to our Private Equity Risk Index research published online. Washington ranks in the top 10 for workforce employment tied to private equity and pension investments tied to private equity, and is among the lowest for Medicare quality ratings at private equity-owned nursing homes. Private equity firms often rely on financial engineering rather than operational improvement to generate returns, using tactics such as leveraged buyouts that load healthcare providers with acquisition debt, dividend recapitalizations that have them borrow again to pay owners cash, and sale-leasebacks that sell real estate and lease it back, locking in rent obligations on previously owned property. We've seen the effects of these methods elsewhere. Some of these methods were used by the private equity firm that owned Steward Healthcare from 2010 to 2020. Last year, Steward filed for one of the largest bankruptcies in decades with billions in liabilities. Steward's former private equity owners reportedly extracted about $800 million during its ownership, including $484 million in dividends from one 2016 sale-leaseback of Steward Hospital real estate in Massachusetts. Washington's high exposure to private equity makes it vulnerable to some of these same risks seen elsewhere. Supporting additional limits on the corporate practice of medicine would provide needed guardrails, protect clinical independence, and help curb some of the financial drivers of healthcare costs. Thank you for your time and consideration.
Thank you, Michael. I believe Aaron is next. Please go ahead and unmute yourself.
Thank you very much. I appreciate the opportunity to speak today. My name is Aaron Keating, and I'm the Managing Director at the Economic Opportunity Institute, which is also a member of the Fair Health Prices campaign. One of our priorities is ensuring all Washingtonians have high quality and affordable healthcare, and strong corporate practice of medicine legislation that regulates undue private equity influence is crucial to that effort. When you have a health issue, you don't go see a hedge fund manager, and no healthcare provider wants one looking over their shoulder when making decisions with their patients. But increasingly, that is what is happening to the detriment of both. Private equity investment in the healthcare sector totaled $1 trillion over the past decade. And while some efficiencies are definitely gained in administration, the downsides of this largely unregulated investment are clear. Research published by Harvard Medical School found patient deaths increased in emergency departments of hospitals acquired by private equity firms, with cuts to staffing and salaries the likely explanation. In a recent survey by the Physicians Foundation, among physicians who have experienced a merger or acquisition in the past 5 years, half said it made their job satisfaction somewhat or significantly worse, and over a third said the merger or acquisition made patient care somewhat or significantly worse. A study published in the Northwestern University of Law Review notes that mergers and acquisitions, which are very common to private equity ownership, can create hospital deserts where people lack access to hospitals and primary care physicians. This is a particular concern in rural areas where hospitals already struggle to attract and retain a robust workforce. Private equity funds and corporate interests should not influence or control the decisions being made by patients and their healthcare providers. Strong corporate practice medicine legislation will help prevent patient deaths, increased costs and hospital closures, and Washington residents who are at risk of losing coverage, whether due to costs or living in a rural location, particularly stand to benefit. Thank you for highlighting this important issue at the Cost Board today.
Thank you so much, Aaron. I'm not seeing any other hands at the moment. Just giving it one more second here. Okay, so I just want to thank everyone for their public comments today. Your input is incredibly valuable, particularly as we are working on the legislative report and shaping our agenda for next year. So thank you. And as always, if you have any additional comments, please feel free to send that to our email address, which I'll ask to be put into the chat as it's a little wordy. Our next section will be discussing the Joint Advisory Committee meeting that took place on September 25th, led by our committee chairs, Eileen Cody and Bianca Frogner. These updates help ensure the Cost Board remains closely connected to the stakeholder feedback and data insights that guide our policy direction. And I'll send it over to Eileen and Bianca.
I think Bianca's going to take the lead on
Yeah.
this today.
Yeah, so feel free to jump in, Eileen, if I miss anything. So we did have our joint advisory committee on September 25th, and I will go over a little bit about what we talked about and some thoughts and recommendations that came out of that meeting. So go ahead to the next slide. So the main topic of the Joint Advisory Committee was related to the data call process and performance against the benchmark analysis. And as you're probably aware already, this is one of the aspects of our Cost Board's ongoing analytic efforts. So go to the next slide. So during this meeting, we just discussed some logistical changes to the data call, including a new tool, a data ingestion tool that will hopefully streamline the reporting process for carriers. It was also discussed that there's an update to reporting primary care expenditures. Next year's data call will collect primary care non-claims expenditures so that we can get a more complete picture on what primary care spending may look like. Our wonderful Cost Board staff walked through a preliminary plan to update the recalculation of the healthcare cost growth benchmark values. The board needs to update these values next year as the current values only run through 2026, which we're already coming up on, which the time is running by fast. This refresh or this recalculation will provide us a new benchmark, set new benchmark values that are based on our prior approved methodology, or this is basically our current methodology, which is a 70-30 split, weighting a historic median wage growth and per capita potential gross state product growth. So that's just a reminder for you all that. So we're just updating these numbers this next year using that same methodology as we've had. So we'll go to the next slide. So as a committee, we reviewed the current attribution method as to help inform staff as they consider changes and improvements to the process. And the goal of the whole attribution process is to assign healthcare spending to the responsible entities, so the larger provider organizations. And our attribution method here in the state is very similar to how other states do this, where spending for individual members is attributed to a PCP, a primary care provider, and in turn, their affiliated provider organization. And the PCP attribution is based on the order as shown here on the slide. So the PCP selection by a member, which is required by a plan, the contract arrangement between the carrier and provider, and utilization history. So this is all a bit of a review, just kind of what we discussed and what was said. So let's go to the next slide. So then our committee members had an opportunity to give us some feedback for consideration as the staff starts in on these updates. Around the attribution process, some of the feedback that was given is that provider representatives on the committee expressed that organizations find it challenging to understand why certain spending is attributed to them. They noted that the carrier methodologies are non-standard and not shared by HCA with the organizations. Additionally, providers and carrier representatives noted that while attribution makes sense in the context of a value-based payment system, which are common in other states, not all hospitalizations flow from these arrangements. So then we got feedback around the benchmark refresh. Some of our representatives on the committee noted that the benchmark methodology needed to be revised and suggested separate benchmarks for high growth subcategories like pharmacy spending. Others noted that that by breaking out higher growth subcategories, that it was at odds with the intent of the benchmark. So this is just showing the kind of the other side of that equation, and that its purpose of doing the benchmark is to measure spending against a goal. And when the goal isn't met, a cost driver analysis can help us understand why. Other remarks that were made was that the purpose of the benchmark is to ensure spending growth is affordable and reasonable relative to wages and wage growth. With current affordability trends alone, more than 50,000 people are expected to become uninsured because they can't afford it. Revising the benchmark methodology due to high cost growth doesn't quite address the affordability crisis facing these Washingtonians, as these are, again, the remarks that were made during our committee meeting. I think that was our last slide. Okay. Eileen, do you have any other things to add? Anything else that we missed?
No, I think the only thing I would add is that we heard quite a bit of frustration on how things are signed. You mentioned that, but I think that that's probably where the highest frustration level was.
Yeah. Any questions from the cost board members? Okay. And if not, I'm going to pass it back to you, Ross, or Michelle. Not sure.
Thank you, Bianca and Eileen. That's really helpful. Thank you for continuing to chair each of those subcommittees. We appreciate your guidance and leadership in those conversations. I think there'll probably be more context to some of that data refresh after we have had a little bit of a sneak peek in the legislative report today and in the next month's meeting where the data team is bringing the results of the data call. So it will have more context in our November 20th discussion. And then we can continue those discussions in 2026. At this point, we'll return to one of the other committees, our nominating committee, and Carol Wilms is going to give us an update of that discussion.
Okay, thank you, Michelle. So the committee met on October 2nd. The agenda, if you'll move to the next slide, was to review nominations for a few vacant positions and to make recommendations for the board's consideration. I'll start with the Primary Care Advisory Committee on the next slide. Has recently lost 4 members of the committee in the past year and had the opportunity to receive 1 candidate for nomination, which is on the next slide. I'll note that there is no number of members serving on the committee required in law, nor representation of a segment or geographic recommendation or segment. So truly, we're just looking for numbers to replace, and staff, I know, are looking for additional nominations for sure. So the candidate that we considered is I believe there we go, Dr. Elizabeth Hutchinson. And her credentials are listed here on the slide, as well as in the committee's packet, I believe in the index section. The nominating committee noted that Dr. Hutchinson's strengths were certainly in primary care and behavioral health experience. Looking to her recommendations from peers, accolades as a teacher speaks to her strong engagement. So we felt this was, while we have just one to recommend to you, we feel it's a strong recommendation. And I'll turn it to voting, I believe, to staff.
Yes, I think you wanted to run through each committee representative and have an individual vote as we go along, right, Carol?
That's correct.
All right.
Yes. I think it would make best sense that way.
Okay, let's do that then. If there are any questions around this suggestion that we accept Dr. Elizabeth Hutchinson, any comments or questions from the board? Anyone wish to provide a nomination? So moved.
I'll nominate.
A second?
Second.
Yeah. Okay. Great. All in favor, say aye. Aye.
Aye.
Any opposed? Okay, so carried. Back to you, Carol.
Great. Thank you. So now we'll move on to the next committee requiring action of the board is the Stakeholder Advisory Committee. And this committee does have specific committee member positions and then also the nominating entity to recommend nominations. And so we will start with the Washington State Medical Association, their member resigning. Dr. Nariman Hashmati is coming off of that committee. And also there will be, we'll then consider the WSHA nomination in just a bit. So we'll go to the next slide to consider the WISMA nomination. In this, we had one nomination recommended to us from WISMA, that is Dr. John Bramhall. Certainly the committee discussed the credentials and you know, very impressed with those and felt it was a qualified and deep background in medicine, strong engagement, representing physicians and surgeons in Washington State. And I believe on this one, the next slide, the committee had noted that WISMA is required to present 3 nominees, but it only presented 1 for our consideration. So at the time of the committee meeting, we asked that staff go back to WISMA for additional nominations for us to consider. It's not that we were rejecting Dr. Bremmel's candidacy. We just really would like to have seen a stronger candidate profile. So since the meeting has occurred, staff has an updated report from WISMA. Maybe I'll turn it back over to staff to address that.
Sure, happy to speak to that. We did communicate with WISMA, and they identified that this comment is also included in your packet as well under the public comment section, noting that they had difficulty finding candidates for this position, and that you know, they work with physicians and that time is incredibly valuable, and so asked for the nominating committee or the cost board to move forward with consideration of just this nominee that they put forward.
So again, I'll reiterate that the nominating committee was comfortable with this candidate and would have recommended them, I'm sure, for nomination to the board.
Good. I know we're getting into the vote on the next slide, but I would share that I also got a great endorsement from our chief medical director here, who says he's fabulous to work with. And with that, I would move that we, as a board, accept the WISMA's nomination and finalize that today.
Second.
Perfect. Oh, wait. All in favor, say aye.
Aye.
Any
Aye.
opposed? Hearing no opposed, we accept Dr. Bramhall's nomination. Thank you very much.
Michelle, this is Leah. Could I just ask that maybe we have some follow-up to see how for future areas like this where, you know, really a panel of folks is the ideal for the nominating committee to consider maybe working with WISMA, I see their note there, on ways that we can work with them to publish it, or see if there's anything else we can do so that for the future we do have more candidates.
Sure, we can happily ask again into the future, and just noting this was the same issue we found the last cycle, that they are challenged to find physicians willing to spend their volunteer time at our committee meetings. So I'm happy that they have
Got
someone
it.
who is willing to come. So
Absolutely. Thank you.
All right, moving on to the next committee member position, that is the Wishes represented member. And in this, we did have three nominees to select from to replace Eric Lewis. And so on the next slide, the three nominees that were considered by the nominating committee are before you. Wish's recommendation was Jason Hotchkiss based on his experience. The committee reviewed all nominees and their credentials. On the next slide, the committee's recommendation to the board based on broad background and proven commitment to policy work is a recommendation for Katerina LaMarche to the board to represent this spot on the committee. So I'll turn it over to staff.
thank you, Carol. I know that Ross has had some follow-up conversations with Katerina to ensure that this was acceptable.
Yes, I did notify Katerina that the nominating committee had identified her, and Katerina was welcomed that opportunity in bringing this to the cost board for a vote.
All right, with that, would someone like to make a motion to recommend Katerina?
I'll make a motion.
Second?
Is there a second?
Yes, second.
Great, thank you. All in favor, say aye.
Aye.
Any opposed? Okay. Thank you. Approving Katerina LaMarche to serve on the Stakeholder Advisory Committee. With that, thank you. I wanted to say thank you to all of the members that participate in the nominating committee and spend their time helping us sort through these multiple advisory committees and keeping them fully staffed with volunteers. So appreciate your time and attention to that. And then I wanted to have a point of personal privilege to thank Carol in particular for her time serving on the board and this committee. Really been an active and valuable presence throughout this time. And I'm sharing that because Carol is retiring. This is her last meeting with us. And she's excited to start her next adventure. If you would like to share a few words, Carol.
Well, it's been an honor to be on this board. Thank you, Michelle. And I am looking forward to retirement. We'll definitely take some time away for myself with family, and then who knows what's in the future after that. I don't know, but that is my plan for now. Yes, their Association Washington Cities is having a hard time letting go, as I am. It's about the relationships and the friendships built along the way. So it's the hardest thing to say goodbye to. 43 years. Yeah. Yeah. So that's a hard habit to break.
Congratulations, Carol.
Thank you. Thank you very much.
Noting Carol's retirement, we will be seeking additional volunteers to serve in the nominating committee. We would like to have at least 3 members. We have 2 still remaining. So if there's anyone interested in volunteering today, that would be lovely. Otherwise, we will look to hear from you and with feedback in the next couple of weeks. But anyone ready to volunteer today? We don't meet very often. Or say, what is it, twice a year maybe?
Yeah, I think it's scheduled for 2 times for 2026. Or as needed, I should say.
Or as needed, right. We are anticipating future committee members, so there should be a meeting in the future, but All right, I'm not seeing any hands jumping at this volunteer opportunity at the moment. We'll look to follow up and nag some of you if we don't hear back. Thank you. All righty. Now, I believe I saw Judy on. Let me just double check if Judy made the meeting.
Yes,
She has
hello.
made it out of court today. She was testifying in a lawsuit. So, Dr. Zerzenthal is here. She's our chief medical officer, and she has been chairing the primary care committee. So she is here to share some of that report out for us. Judy?
Yes, thanks. So if you can advance the slide, it's great to see all of you today. I'm going to share where we are with some data and then talk about the committee's recommendations. So next slide, please. So as you may remember, in 2023, the Primary Care Committee defined and adopted a new standard definition of primary care spending based on not only the service type and the provider type, but also adding the care setting. So for example, urgent care or an ER would not be considered primary care, even if a primary care person was working there. Also, the provider type did not include OBs, so there were some relatively big changes, narrowing the scope to really focus on we are certain these folks are primary care. So I'll talk about what that means in a minute when I show you the graphs, but we expected it to be more narrow. We also included non-claims-based payment definition, like capitation, if a practice is doing that, but also quality incentives and maybe care coordination funds. And so it was first used in our 2024 reporting. And I think really enhances the accuracy. We are confident the spend is really primary care and not specialists. It'll help us with accountability and sort of moving that target along and aligns with health system transformation. So next slide. So this is a reminder of the services, the what, the providers, the who, and the locations, the where. And I'll move that on. So the results, drum roll. So you will not be excited. Like you will expect that the blue line is our new definition and the green line is the old definition. And so the blue line is lower than the green line for that same year in 2022. We measured it for a couple of years, so you could start to see a trend line. And so there's a slight drop in that, which I think reflects true primary care. I also want to say that nationally, primary care spend has went down this last year and has been going down the last couple of years. And so some of the lower bit, especially the primary care expenditures, if you look at it on a per member per year basis, which is not what we are doing, but is what Rhode Island is doing now and what they recommend doing. So we wanted to show you both. But how we are measuring is the amount spent on primary care as a proportion of total medical expenditures. And you can see that that went lower in this past year. And again, that is sadly not unexpected given where things are. So next slide. Looking at primary care expenditure by market. So now we have the blue line is commercial, the green line, the top line is Medicare, MCO, and the purple line is Medicaid. And so we again have the primary care by market, the per member per year spend, and then next to that, the proportion of primary care spend to total medical expenditures. And you can see if we look at the individual, it goes up a little bit. But if you look at it as a percentage of total market expenditure, it is totally flat to downward. And so I see Eileen shaking her head. That is a huge bummer and is not going the right direction. So next slide. So looking at the carriers, so we did sort of look at the spread of what happened when we changed the primary care definition, looking at the 14 carriers. So the old definition is the green, and you can see there's much wider variation and a little bit more extremes. Whereas if you look at the new definition, folks are grouped a little tighter. And there's less variation. So this also tells me that I think we're on to the right thinking with this new definition. That it's really it really represents primary care. Next slide. So looking at other states, and this is just what I talked to you about in the other ones, but this is broken down by state. And so or the darker gray, there's a lot of messiness here, but it compares Washington, which is the green bar, to Oregon, Massachusetts, and Connecticut, which are the various shades of gray bar. And then the blue is the overall US trending based on the National Academy of Science, Engineering, and Medicine definition. And sadly, in general, the trends across markets are directionally the same as for Washington in not going the right direction. Next slide. So the Primary Care Advisory Committee talked about this at our meeting about a month ago. And I want to remind you that we are looking at 4 key areas used to evaluate primary care expenditures. So direct investment, paying more for primary care services. Capacity growth, so reducing barriers so that primary care can maybe see more folks if they're not, or add to the workforce. The blue going around the circle is in patient behavior, so increasing patients' use of primary care services rather than the ER or urgent care. And then the last one is reducing expenditure on other services. So if you spend less money on the total, then your primary care, if that is held constant, will go up. And so these are the 4 areas that we looked at, and that 12% target, which is our goal from the legislation, is in the middle to remind you all of that. Next slide. So these are our recommendations. The first one is to increase primary care spending by 1% annually. You may remember we brought this to you last year. The committee recommended 2%, and you all voted for 1%. And we were hoping that the legislature would adopt that or pass something to sort of set some goal and movement in primary care spend. That has been successful in other states, including Connecticut, Rhode Island, and Oregon. If they have a little sort of carrot and stick and an expectation of how much primary care spend can go up. And so we are asking the cost board to consider that recommendation again. One thing that the committee felt strongly about in helping this, they recognize that this might be a hard thing to do and that it could be redistribution since we don't have funds rather than new money. They also, and so that's why it says, oh, I'm not the slide. So increasing the primary care redistribution is one idea. Also, one of their thoughts was that if other services are being cut, to not cut primary care reimbursement by the legislature, which would also be a way to raise primary care spend. The second recommendation is to increase Medicaid reimbursement. You'll remember that last year the committee recommended to raise Medicaid primary care reimbursement to at least Medicare levels. Again, we think that that is probably not going to happen. And so the sort of caveat or what the committee would like is that we maintain the current reimbursement levels for services already at or above Medicare rates to not decrease primary care spend. Next slide. So these next 5 are really things that are ongoing work. And so they don't require anything new to be done, but patient engagement, which is prioritized as a place to lean in this year that the committee would like to sort of think about how do we let people know the importance of primary care and help them seek it. The second one is multi-payer alignment and continuing the work of the multi-payer collaborative to align standards, metrics, supports, and payment models. There is no longer a need for alignment with the federal Making Care primary model since that has ended, but in thinking about that, the third one is that we are still endorsing the Health Workforce Council recommendations to expand primary care access, and they have some ideas about growing workforce. None of that is a fast fix for any of this. Fourth is alternative payment models and continuing our use of the Healthcare Payment Learning and Action Network framework to track and set our spending targets and to really, most of our value-based payments are actually in primary care already, but continuing to measure that and sort of keep track of that. And then the last one is ongoing agency and also the national HCP land survey is in progress. So both of those surveys should come out sort of late fall, early winter, which I think will help us. The other, we are not in our individual reporting of this going to report the primary care value-based payments. The other piece that I forgot to mention when I was showing you the data is that we did not get the non-claims-based spend for primary care collected this year. So hopefully that will increase the primary care spend some. Some folks on the committee were reluctant to take a lot of action without knowing what that non-claims-based spend is and how close we are to 12%. However, with the claims-based going down, I'm not sure, and general woes in healthcare, I'm not sure that we're going up in primary care, even including those non-claims-based payments. So next slide. I think this might be the end. Oh, yes. So discussion. Do you have questions, comments, things for us to talk about? Bianca.
Thank you for this reflection. A couple questions. So around the Medicare graphs earlier, those were Medicare managed care organizations showing, that Medicare spending is X number of dollars per person. Do we know what Medicare fee-for-service looks like relative to that? Because it looks like the recommendation is based on. Yeah.
Vishal, I think I saw you on. Do you have thoughts about that? I'm not sure why we don't have both of those numbers, but I suspect there is a reason.
I'm sorry, Bianca. Could you repeat that question, please? Which two numbers?
Why is the data that I shared about primary care spend, why is it Medicare HMO? And do we have Medicare fee-for-service?
So our data is limited in that. Medicare does not provide us the provider level attribution necessary to be able to assign the primary care or separate it out. The data that we receive from Medicare core CMS for fee-for-service does not break out professional claims or professional spending between primary care and professional specialty. It's a limitation of the data we have. But the Medicare Advantage, because we get that directly from the carriers, we are able to have that distinction.
So the recommendation around at least maintaining the rate for services to be at Medicare rates for the Medicaid program to maintain at Medicare rates, is that easily identifiable? And
the rates are easier because the fee schedule is published. So we know what the individual reimbursement rate is going to be. It's the total spend that we don't have an idea of what that is.
Okay.
Yes.
Yeah, I think I understand that it's probably publishable. I think to some degree, I'm kind of wondering what the universe of primary care services are. If you're saying that you can't quite figure out what that set of primary care services are within the fee for service model, unless maybe it's the attribution part that's more of an issue than.
So again, the difference here is we're looking at the aggregate data from the data call. When we get to the actual analysis using claims data from the APCD, we will get a better idea for what that is, because those are again based on the where, the what, and the who. So we have that level of detail from the claims side, even for Medicare fee-for-service. It's the aggregate reporting that we get as part of the board's data call that has that limitation.
Okay.
But overall, I think because these data sets are complementary, we can put these side by side and get a fairly good picture of what the landscape looks like.
Great, thank you. Then can I just ask for the workforce development piece? I know that Renee Fullerton kind of mentioned this in her public comments around the Workforce Council's recommendations that primary care wasn't kind of like the key focus in this past year. Can you say a little bit more what the recommendations are?
That is an excellent question. I would have to get back to you. They didn't focus on primary care this year, but they have passed recommendations on primary care, and so that is what we looked at, and that those were still things that should be pursued.
Okay.
Eileen?
So you're right, Judy, this is pretty disheartening. Can you remind me, when did the legislature pass the goal of 12%? Wasn't it like 18 or earlier?
I don't know. Michelle, do you remember? I want to
believe
say
the direction to the cost board, I believe, was 2022, and that was to offer recommendations on how to get to a goal of 12%.
Okay. Well, so then, I mean, basically, it has not changed since.
it has not changed since we
Yeah.
started.
But this is the other thing, trying to refresh my memory here. Didn't the legislature actually increase the primary care Medicaid rates a few years ago? I mean, they tried, not a lot. I'm not saying a lot, but that they put some more money towards primary care, I thought.
Yeah, there are investments in our Medicaid primary care reimbursement, and those will continue as a condition of our 1115 waiver.
Okay.
So that is also built in. It is gradually increasing. It is not at 100% of Medicare. I think it's around 80, but I don't remember per code. And then we've also, the legislature has made some investments in the behavioral health primary care on the Medicaid side. And then, of course, we had legislation passed last year that makes an investment on the commercial side for PEB and SEB. So there is a new floor for requirement going into January 27 that will focus on primary care and behavioral health payments at 150% of Medicare. So that
Well, and I remember the public option has it in specifically calls out primary care as a higher, or they has a floor for primary care.
Exactly.
Yeah.
So yes, I
So
think it's 135.
okay, just trying to remember what we've done.
There are gradual investments, but
yeah,
they're pretty gradual.
But it also looks like other states have done similar things, but looks like maybe Oregon's the one that's done the best. Am I right in?
Yeah, I think Oregon is doing the best, and they have legislation to like require an increase by 1 to 2% a year. And so I think that's when they really started seeing some changes in that. Our current legislation from 2022 is still sort of squishy. Although one piece that did get passed, and I think it was last year, Michelle, is that OIC will now be doing a report. And so in the rate filings and in the information they get from the commercial carriers, they're going to be measuring primary care spend, which I think is also like sort of another like right step in the right direction. And what is missing is how fast do we get there, or are there ways that we can get there?
Thanks.
Jane is here with a question or a comment on that OIC reporting, I believe.
Right. So we have, for the first, let's see, we're going to be sending out to the carriers to include in their annual financial statement a whole additional supplement around primary care spend that's going to include non-claims as well as claims expenditures. And the beauty of that is we're doing one report for Medicaid, PEB/CEB, commercial. So that way we're sort of doing everything in one report. So we'll have consistency across. And I think the first report is due in from the carriers in July of 26 for 25 expenditures. And then Judy, I just had a question. So making care primary, poof, it's gone. Can you give us a little bit of an update about the multi-payer collaborative and sort of the status of those efforts?
Yeah, sure. So this year they have worked a fair bit on attribution. They've had a group of clinicians, uh, what we call a learning cohort, come work with them because that is seen as a pain point from the practice side. And so we worked out some agreement of sort of how we think about attribution, and some of it involved education for providers and sort of understanding how that happened. There's also been contracting that has happened, and then we have launched what we call our recognition program. It's been a very slow launch, I'll say, this summer. But that collects information on practices, on where they are in the 10 pillars, and is information that I think will be helpful for the payers to sort of focus on what do practices need, how do we work together to help get that practice what they need, whether that's behavioral health integration or changing its hours, or, what are the places that they can work on between where they are now and very high performing, high functioning primary care?
And I'm assuming all those, to the extent that carriers made investments to try to build capacity of primary care practices, those are the kinds of non-claims expenditures that would count, quote unquote, toward the percentage spent on primary care?
Yes, I think it would if they were helping a practice. One thing that now I can't remember if I presented this to you last year or not. Greater Health Now, the ACH, did a pilot of our recognition tool with 10 practices. They had one person that was a nurse practice facilitator, and she worked with them over a little over a year, starting to like fill out the tool. Can practices fill out this tool? How hard is it? And getting a baseline of where they are, and then working with them to see if they could advance. And that one person in a little over a year was able to move up all practices up one level. There's 3 levels, with 1 being starting and 3 being advanced primary care. And there was even one practice that moved up 2 levels in the year, which was pretty impressive. And so the multi-payer collaborative is talking about that. I think we were hopeful that University of Washington, in collaboration with a lot of people, had applied for an ARC primary care extension grant that would have given us funds to help practices move along the continuum and provide technical assistance and help for practices. And that grant got canceled. So we will not get that, even if our grant was amazing, which I think it is. So I think it's a gap in how can we help practices evolve as well as support them in their current day-to-day work.
Lois has been very patient with her hand up.
Yes, Lois.
A couple of things. I have a Regents plan this year, and my first two visits were a $1 copay. I don't know if Regents is big enough to have a major impact, but maybe that could be part of the primary care spend being a little bit lower. Just a thought. I don't know if that's something they've done previously. This is my first year on a plan like that, and it's through the exchange. One of my questions, which you've already kind of covered, was what is Oregon doing? Because that looks fantastic. And also, I was reading recently about a lot of trouble recruiting and retraining specifically primary care physicians or nurse practitioners in Washington. Is that something we're looking at all?
Great. Yes, I'll sort of take them one at a time. So, Regents Year Plan sounds amazing, and a number of plans have started to do either no or low cost primary care visits to sort of encourage people to go to primary care. They still pay their usual amount to the provider, and so it would still count towards that primary care spend, but hopefully it made you go to primary care.
When you pay as much for insurance as I pay, I go to the doctor for a hangnail practically because
you want something out of it. So
$30,000 a year, I'm not
yes.
going to have an issue.
And Regents is part of our multi-payer collaborative and is working, and we have been working on the PEB side with them as well to sort of find ways to advance primary care. The second thing, yes, there is a shortage of people going into primary care, both doctors and nurses. And yes, it is not keeping pace with the people that are leaving primary care in Washington state. So that is not going to be helpful in the future. And it's part of some of the workforce things that we're working on. Bianca, I saw your hand go up. You can probably talk about this much more eloquently than I can.
No, I mean, you're doing great, Judy. I just want to just note that, I mean, certainly MPs and PAs and physicians are all very important parts of our workforce. In addition, there are a number of people who do provide primary care as part of the team, including medical assistants and behavioral health providers. And so I think we can certainly probably look at other ways to also expand primary care workforce as part of the team, in addition to those who might be at the kind of top of the food chain, so to speak. So just want to kind of point that out. I guess part of it, I am wondering how one, and not to jump in, Lois, maybe you probably still have more comments, but okay, I am curious if in looking at the two recommendations, that one of them is to increase 1% of spending per year, which I agree, some kind of method to get towards 12% certainly needs to be stated. It was always something that puzzled me, why we have a benchmark with no time frame or mechanism. But I am a little worried that there isn't really a clear mechanism to make clear about how we're going to get there. I would love to know how other states are doing that. And it does seem like workforce investments is a big part of that. And if the Workforce Council hasn't quite, updated their report, it'd be great to leverage the Workforce Council to provide even more guidance on what the primary care workforce expansion would need to also look like relative to an increase in spending. Just want to put that out there because in addition to making sure that we're paying people properly, we probably also need to figure out how to increase the actual size of the workforce or stability of that workforce. So I didn't know if that was something that could be put on the table as part of the considerations?
Yes, we'd be happy to talk to the Workforce Council. And yes, I agree. Workforce is a piece of this. All of these 7 things, I think, are puzzle pieces that will get us there. And that's why the committee is either continuing or has slightly edited their recommendations from last year.
I recognize it's a tough time when Medicaid is on the chopping block and federal programs are kind of going by the wayside. So I'm just trying to think where else we can try to encourage areas of investment for that 1% if we can't change payment rates very easily or, push value-based payment at a federal level. I appreciate the work.
Yes, yes. Next slide. I guess I should have said this before the discussion, but the legislative report that is coming from the cost board is going to reflect these recommendations. And we hope you will continue to support the work of the Primary Care Advisory. And I think now is time for a vote. Do I pass that back over
Thank
to
you.
Carol, Michelle?
Yeah, I'll take that. Thank you, Judy, so much for your time helping guide the primary care committee and bringing the recommendations and the data overview to the board. Appreciate that. I will note that the draft legislative report you have in your packets today does take some liberties to incorporate the committee recommendations, noting that those are open to draft and feedback at this point. The staff have tried carefully to weave recognition of the committee work and appreciation for that, and recognizing that the agency is in a tough spot financially and cannot endorse more spending per se because we have not been allowed to put that forward in a decision package or budget request this year. We in fact are having requests for reductions for the most part, other than our new federal work that we are being required to prepare for around the Medicaid changes that Bianca just mentioned. So there is a soft line around accepting the committee recommendations and not going too far to say we must spend more money on brand new money or invest in new primary care payments at this time.
So, for example, on the recommendation to increase primary care spending by 1% a year, can we consider asking the legislature to legislate on that issue? Is that something that we can do?
We took a little softer line in the draft if you'll have a chance later to look at the draft report.
Okay.
And offer some comments and draft feedback on that. Be helpful.
Okay.
Other comments or questions around the proposed vote today?
Yeah, this is Jody Joyce. I have a question. So it sounds like we're using the term draft language. So what are we voting on? Are we voting on the intent? Are we voting on the draft language? Are we voting on an opportunity to provide input on the draft language? It seems a little premature to vote on something where the term draft language has been repeatedly used.
And maybe that's my misuse of words. The committee recommendations have been put forward. So the suggestion from staff is to recognize the committee recommendations in the legislative report. And those have been incorporated in the language that you all have in the draft report today. So the staff took liberties to include some of that advanced language, knowing that we're all going to give feedback in the next 2 weeks as well. But it does recognize the committee recommendations.
Thank you.
Other questions or comments? Okay. Is there a nominee to accept this motion?
I so move.
Okay, is there a second?
Second.
Thank you very much. All in favor, say aye.
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 Any opposed? Say nay. Not hearing any. Motion is approved. Thank you. Thank you so much, Judy, for your time.
Yes, thanks all.
All right, now I believe we're ready to welcome Senator Robbins. Oh, we're having a break. Thank you. All right, staff will correct me. We have a short break, so we'll be right back. At what time?
And we'll be back in 10 minutes. So if folks could return at 3:25.
Thank you very much. All righty. I think we're back from break. Thank you all for that brief break. And I see that Senator Robinson is on to do our next presentation on corporate practice of medicine and an opportunity to help fill some of these gaps with oversight in our market activity. So, Senator Robinson.
Hi, well, thanks for having me. It's a pleasure to be here with you all this afternoon. Are we gonna, yeah, there we go. Okay. So, I've been asked to give a bit of an overview of a bill that I introduced last session, Senate Bill 5387, regarding the corporate practice of medicine. And so I'll talk a little bit about why, what happened last session, and then what what we're thinking about heading into the 2026 session. So next slide. The origin of the bill really came from hearing from other states and also seeing what's happening in Washington State with consolidation of healthcare, and private equity getting more and more involved in healthcare. We know in some states that has led to some pretty significant changes and hospital closures, et cetera. In any case, there are questions about are licensed healthcare providers, do they still maintain the ability in all situations to make clinical decisions? That's really what corporate practice of medicine is about, is who is making those clinical decisions. We have corporate practice of medicine case law in our state. It's not a new concept. It's been around for a long time. Actually, it was first, the origin is around sort of what my mom called quack medicine, to make sure that licensed healthcare providers were the ones providing healthcare many decades ago. So we're taking a look at that old case law and attempting to update it for what we see in our modern current healthcare environment. So we can go to the next slide. So in 2025, earlier this year, I introduced Senate Bill 5387 to codify existing corporate practice of medicine case law standards and then to modernize the statute, again, to ensure that clinical decision-making is free from interference from what are new and complicated, in many cases, corporate structures, to make sure that patients know that it's a licensed healthcare provider who's making the decisions that affect their care. And also, importantly, to provide our state agencies with the ability to investigate and enforce corporate practice of medicine laws. We can go to the next slide. So to draft the bill, we started with a NASHB model law in this space, and then worked with our relevant state agencies, primarily Department of Health, also Healthcare Authority, Office of Insurance Commissioner, and to some extent, the Attorney General's office, although they were in the process of sort of getting themselves organized with the new Attorney General. At the beginning of last year, we've had more conversation and involvement with them over the course of the year. Along the way, the bill did gather support from the state agencies who would be involved, certainly from consumer advocates who are very interested in this concept, healthcare unions, and then individual healthcare providers were willing to step forward in some cases and say, yes, this is important. We need this protection. I was dismayed that I didn't feel like a lot of healthcare providers felt like they were able to really be public with their support, but some did come forward. The bill went through a few iterations, as all bills do. We got feedback from provider groups, from the Washington State Hospital Association, from telemedicine companies, which is a whole modern iteration on corporate practice of medicine structures, insurance carriers, and others. We took a lot of feedback, tried to address concerns along the way. We had 2 subsequent substitute bills as it went through the healthcare committee, and then Ways and Means. But we weren't able to get it to a point where there were still significant concerns and fairly broad concerns about the bill, and just sort of ran out of time to continue to do stakeholder work and make changes. So it did get through the Healthcare Committee and the Ways and Means Committee, and then died in Senate rules. So that's where the bill is right now. And we can go to the next. Some of the challenges that we faced and identified as we went along were, just as I said, identifying healthcare providers to include. So do we include all licensed healthcare professionals, which obviously is a wide breadth? Do we include massage therapists and physical therapists and, the whole range of healthcare providers, or do we limit it only to physicians? We kind of had that in some of the parts of the bill. Nurse practitioners really wanted to be included. That seemed appropriate. It's hard to know where exactly what to include and where to cut off. I would say there was quite a bit of pushback on some parts of the bill from the dental community. They felt like they had already been protected by previous legislation for their industry. So lots of different pieces of, lots of feelings about who should be in and who should be out. And then, how do you ensure accountability with all the various iterations of corporate structures in medicine now? It became very hard to draw a line between who is making what decision. So that everybody had sort of a different tale of where that accountability lied and how the bill would address or not address that. Including the next bullet point here, the relationship between providers and facilities, provider practices that are owned by larger hospital structures or other sort of corporate structures. Just the line between fiscal decision-making, business decision-making, and clinical decision-making became very hard to tease out and put into bill language. And then, the current healthcare market is really different than it was even a few decades ago. And so telemedicine, for example, which is now an accepted part of our healthcare landscape, wasn't really contemplated when corporate practice of medicine case law was written decades ago. So how do you account for those telehealth companies, and who, again, where is clinical decision making happening within that structure? And then finally, a fairly significant hurdle that we had to think about, staff did a lot of work to try to come up with solutions here, was where do we enforce this when we do pass something? Is it at Department of Health, who has regulatory authority over healthcare facilities? Is it in the Attorney General's office? The Attorney General's office is not currently equipped, I guess, not staffed to really provide this level of enforcement. So that would, if we go with the Attorney General's office, that would drive a large fiscal note. Of course, we're in challenging budget times, so that was hard to figure out. And then we looked at the licensing structure for healthcare professionals and thought that that was a place to put accountability, so that as providers were getting their professional license, that they would need to attest that they were the ones making clinical decisions. That was met with some pushback from the professionals themselves. They didn't feel like that was a fair place to put them. So that is, I would say, still a challenge, the whole enforcement. Where does that happen? Who's responsible? I think that's still a challenge that we're working through. So we can go on. So we have been doing some work, listening to concerns, meeting with agencies in preparation for continuing to work on the bill in 2026. As I said earlier, it sits in the Senate Rules Committee right now. We could potentially put a striker on and try to move it out of the Senate. Those are decisions that we haven't really made yet. We also know that our neighbor state of Oregon, who I think we're going to hear about next, did pass a corporate practice of medicine bill earlier this year. So comparing 5387 to what they passed and trying to learn lessons from them, although it hasn't been implemented yet. And then continuing to think about, how we would enforce anything that we do pass, looking at language that would focus on physicians and nurses only and sort of cut out all those other professions. I think that where most of the concern is around physicians, probably physician assistants and nurses, nurse practitioners. So focusing there, it will make the bill more understandable, quite frankly, because we had to bring in so many different RCWs as we included all the other professions. We are considering adding whistleblower protections for those for clinicians who would report clinical practice and medicine violations. We have been asked to consider a non-compete for healthcare providers, which is a bit out of the, it's not exactly corporate practice of medicine, but it is adjacent and perhaps could bring some support and also some opposition, I'm sure, to the bill. Then again, as I was saying, like looking at where do you draw the line between business decisions that are made and clinical decisions that are made, and how do you thread that needle in a complicated corporate landscape right now? It's hard to figure that out, to not, understanding that practices, physician groups do need capital investment, but how does that influence how the practice is run, who makes decisions, and how do you structure that in statute I'm finding to be pretty challenging to sort through. And then some people are asking for much more, like in structure and enumeration within the bill of exactly what are those corporate services, billing, scheduling, hiring, defining exactly what that is. Personally, I don't like to put a lot of that kind of detail in bills. I think it becomes problematic over time, but there is request from some parties to make it more structured in that way. So we're continuing to think through all of these suggestions from a lot of different stakeholders and rewrite sections of the bill, trim it down, and hopefully make continued movement in 2026. I think that's it.
Great. Thank you, Senator Robinson, for that nice overview of your bill. Are there some comments or questions from board members? Eileen, you look like you might have a question. No?
Good luck.
Lois?
Is there someone or some organization, I mean, other than insurance companies, who's going to be your biggest challenge to get this by, do you think?
There are, I would say it's insurance companies, it's hospitals who own physician practices and or who have physician practices under their umbrella, I guess is a better way to say that. And the practices themselves. So think of large either primary care or multi-specialty practice groups who are set up as professional
Like a
service
Vancouver clinic.
organizations. So there are just lots of groups and people. I'm not even sure well, we kind of cut out telemedicine actually. That was the only way we could figure out how to deal with them, but I think they're still coming back with some concerns. So I think it's broad. I'll just say that. And it as I talk to some of these groups, it's unfortunately almost like it feels threatening to their existence.
Oh. Okay. Thank you.
Other questions from the board? Leah?
Was there anything you learned from Oregon yet about, was it more that was successful?
Well, one thing that I think we've pretty much decided on after seeing Oregon is to limit it to physicians and nurses rather than the whole breadth of licensed healthcare providers. So I would say that was one takeaway. And then, I wish we had the luxury of seeing them implement a little bit because I am curious to see how their rulemaking and implementation goes. But if we want to move in 2026, we won't have that.
What did they do for enforcement?
Well, they have a separate, you probably know, a separate state agency, I believe, who does their enforcement. Maybe it's within their equivalent of healthcare authority, but they have a different structure than we do.
They have some additional mergers and acquisition oversight responsibility in Oregon, and the board recommended last year as well for the legislative consideration. So there are some additional components around that market oversight that Oregon already has in place that I personally think that we should continue to endorse and hope the legislature will build more of those tools over time. So thank you so much for coming today, Senator, and sharing your bill. We look forward to some good discussions this session and opportunities to support you in that work.
Great, thank you.
Ross, I'm just checking our next guest is still not here.
He's just not in as a panelist.
On his way.
Yes.
All right, we're pausing. If we could talk slowly for a minute. Anything you wanted to add in there, Ross?
I will just maybe spend a minute introducing our next panelist Hayden Rookley, who is in the faculty at Brown University. And he is coming to speak about his experience with assisting Oregon last year with expanding their corporate practice of medicine law. So hopefully that will follow up nicely to Michelle's comments here today. And I think we're just getting him situated so that we'll be able to hear and see him. So
I can see Hayden is online and I can see his face now, so
Yes.
we can
perfect.
hand off to you, Hayden. Or did you have more introduction?
No, Hayden, if you're able to unmute yourself, then yeah, please go ahead.
Wonderful. Well, thanks so much. Can folks hear me?
Yes.
Great. And do you all have the slides to advance them, or am I perfect? Okay.
Yes.
That looks great. And then my understanding is about 30 minutes total. How much time for Q&A, if any, would be preferable?
I think we can probably incorporate just a few minutes after your presentation for some Q&A.
Okay. Wonderful. Well, thanks for the introduction, and thank you all for being here today and for inviting me to talk a little bit about uh, Oregon corporate practice of medicine generally. As was mentioned, I'm Hayden Rookley. I am a senior fellow at the Brown University School of Public Health. And amongst other things, I research and write about issues of corporate consolidation in the healthcare sector, and specifically on the history and potential revival of state bans on the corporate practice of medicine. So it's great to be here to speak with you all and to share a little bit specifically about Oregon's experience in reviving and updating their CPOM ban. If you'll advance the slide, please. So much of this may be review to folks here, but one of the most notable aspects of our evolving healthcare system is the degree to which the provider landscape has changed over the last number of decades. We are now in an environment in which most physicians are employed as by some sort of lay corporate entity, as opposed to owning their own physician practices and being employed by other physicians, or being, as was historically often the case, shareholders and owners of their own physician practices. We have seen the rise of hospital employment really steadily increase for decades now, starting in really the 90s. A hospital merger wave in the 90s has generally continued apace. And today we see that the hospitals are the predominant form of physician employment, but certainly not the only one, and actually not the type of lay employment entity that is increasing most rapidly. In the last decade or so, we've seen a sharp increase in non-hospital corporate employment of physicians. And so here we're talking about retailers like Amazon and Walgreens, insurance conglomerates, insurance companies increasingly restructuring to own medical practices, private equity investors of various forms, drug distributors and drug wholesalers. So there continues to be a continued trend towards corporate employment, and by more varied types of corporate employers. Next slide, please. So this, and forgive if we had some issues adapting the format on the slide here. That was probably an issue on my end, but I think all the text is the same here. So as I was mentioning, we've seen a number of different types of corporate employment of physician practices rise or come about in recent years. This slide depicts a few examples from Oregon, where, as folks here know, they advanced the CPOM legislation. I think is emblematic of the types of corporate employment we're seeing nationally across the country. So I mentioned insurance conglomerates, insurance companies like United Healthcare. Folks may know that United is now the largest employer of physician practices across the country. Other insurers like Aetna, CVS, like Humana, like Cigna, like Elevance are all rapidly vertically integrating or restructuring as not just insurance companies, but owning various aspects of the entire healthcare delivery and pharmaceutical system, including physician employment. Retailers like Amazon, as I mentioned, we're seeing this is a quite recent development, the growth of drug distributors, so drug wholesalers that acquire drugs from manufacturers and distribute them to pharmacies and to physician practices. They are vertically integrating in a similar way. There's three main players there. McKesson being the biggest one, owns US Oncology. They're acquiring the physician practices to which they distribute their drugs. And then private equity has been an integral sort of accelerant of this corporate consolidation across all these areas, whether it's the McKesson example I just gave or United, primary care, specialist physician practices. We've seen private equity acquire these, often sell to other private equity companies, and then eventually sell to a larger corporate employer like like a United, like a McKesson. So these are the types, to give a flavor of non-hospital corporate employment that we're seeing nationally, and that was specifically the subject of the Oregon CPOM bill, which I'll return to. Next slide, please. So from a policy perspective, there are a few different concerns that have arisen and that have been expressed by policymakers at the state level. One, and most of them I think are somewhat intuitive here. One is the erosion of professional autonomy, morale, and trust. This has come about, I think, especially in the primary care setting, but there's widespread recognition that the medical profession is undergoing rapid transformation. And when it comes to the morale and the professional autonomy of physicians, I think there's pretty broad agreement that it's a evolution, not for the a change, not for the better. So there's a lot of concern that there may be a relationship between this decline in morale and the rise of corporate employment, again, as physicians become employees of these large for-profit entities. This relates to the second two bullets here: disruption of the physician-patient relationship, if and pressure to put profits over patients. These are all related. The general gist here is that as we see more corporatized healthcare, more corporate entities that may be pursuing profits over all else, there may be a decline in the physician-patient relationship that ultimately may not redound to the benefit of physicians and their patients and their local communities. So this is generally, I think, the spirit of the concern that policymakers have addressed when they have begun to kind of re-examine these bans on the corporate practice of medicine. And as I've alluded to a few times, this is one of a number of policy responses that states have looked to, and when they have thought about tools to address rising, corporate consolidation across the healthcare system. Next slide, please. So, as I've alluded to a few times, states, the CPOM bans or state bans on the corporate practice of medicine have long grappled with these issues that we just raised here. Corporate practice of medicines actually date back to the 1800s even, and have long expressed a concern about the potential tension between a lay corporate entity's oftentimes fiduciary duty to pursue profits and the professional and ethical obligations of a physician to put their patient's interests above all else, whether it's the corporation or whether it's themselves. This is again, the professional and ethical obligation of physicians that they, so nobly undertake, and compels them to again, put their patients above all other interests when they are treating them. So it is from this tension again between that duty of physicians and the interest of corporations that we've seen really throughout the 20th century and really into the mid-century, the rise of these bans on the corporate practice of medicine. And what they state quite simply is that for-profit medical practices must be owned either majority or exclusively by licensed physicians in a state. And I think it's helpful to recognize that this is a somewhat capacious understanding of what it means to control medical decision making and to ensure that the experience of patients is experienced within or by or under the supervision of physicians. This is not a ban that simply says that lay corporate entities cannot intrude upon medical decision making, a differential diagnosis in an exam room. This is, again, a broader expression saying that given the myriad decisions that are made in managing and operating a medical practice that impact and influence the nature and quality of care delivered, these laws express that licensed physicians must actually be the owners of the practices. And lay entities can't own practices and can't employ physicians. This is a doctrine that arose initially actually out of the common law. So judges made the determination, again, stemming from this prohibition that unlicensed lay entities can't practice medicine, that there is a prohibition against lay entities owning and employing physicians. It's worth noting that this is a fraught and controversial history. There are certainly aspects of CPOM tradition that have been criticized as a mechanism to protect the medical profession from competition and from lay entities coming in and potentially delivering medical care at a cheaper cost. And that critique is something that gained prominence in the 1970s and 1980s with the rise of managed care and more corporate forms of medicine that led to the widespread erosion of CPOM bans across states, which I will get into in the next slide, please. So as I mentioned, in the 1970s and 80s, we began to see an erosion of CPOM bans. States, while most of them had and continue to have, as I'll talk about here, some form of a CPOM ban on the books, there began to be a number of critiques of CPOM generally, and states began to move away from enforcement or outright repeal or partial repeal of their CPOM bans. And I'll discuss a few different versions of this. One was the express exemptions for certain types of employment or lay employment of physicians. And this particularly arose in the hospital setting and even more so in the hospital-based, provider-based HMO setting. Hospitals the history is inconsistent and varied on hospital employments. It's never on hospital employment of physicians. CPOM bans have never been uniformly applied in that context. There's always been a question of sort of whether hospitals as licensed entities, as traditionally charities, as traditionally nonprofits, as again, traditionally entities that didn't really employ physicians and more so just provided the facility and contracted with physician-owned practices to deliver their services in the facility. This was less of a salient issue when CPOM bans were more prominent. And again, we see variation historically in states that said that hospitals can employ physicians or can't employ physicians. The doctrine is sort of more clean historically when we talk about ownership of the actual physician practices. And here we started to see some erosion in the form of some states just repealed their bans on CPOM. So they just said, we're no longer going to enforce the requirement that a for-profit medical practice has to be owned by a majority or exclusively by physician practices. Any lay entity can employ physicians. We saw that in some states, but most states today have retained that requirement. Again, this is the requirement that physicians who are licensed in the state are majority or exclusive owners of the for-profit medical practices. The primary way, so you might ask, well, how do you have this much corporate employment or corporate ownership of medical practices if most states have that requirement? And this gets us to the predominant form of erosion that we've seen and the subject of Oregon's bill and a number of different states' bills to try to revive bans on the corporate practice of medicine. And this is what's known as the friendly PC or MSOPC contracting workaround. Next slide, please. So, what we began to see over the last few decades in the context of this regulatory environment that again required licensed physician ownership of practices is that lay corporate entities functionally figured out how to own medical practices through a separate corporate vehicle known as the Management Services Organization, or MSO. The traditional model of an MSO is that it is a lay-owned entity that might provide some services to a medical practice, to a physician practice, to help them administer, their medical practice, to help out with certain administrative or back office tasks. It might be billing, it might be some sort of scheduling, it might be some software and analytics assistance. That model, however, has been taken to an extreme degree in what's known as the friendly PC structure. And this is where instead of the MSO providing a service for a fee to the physician practice, they actually, through contracting, are able to subordinate the physician owner or owners to the MSO and functionally control the medical practice through the management services organization. The most extreme version of this is depicted here in this image on this slide. And this is where a management services organization will install a physician who may well be on their payroll, may well be an executive at the MSO, the corporate owned company. And that that friendly physician will be a licensed physician who will be licensed in the state in order to comply with that law. They will be installed as the PC owner to comply again with the state law that requires that physician practices are owned by a licensed physician in the state. Oftentimes you see these friendly physicians who are licensed in many, many different states to serve this function, kind of this paper function. And through this contracting arrangement, through a management services agreement with the PC entity and the MSO is able to arrogate really all the decision-making power to the MSO and functionally control the practice. They will own all the administrative, they will own many, if not all, of the physical assets. Through contracting, they will take exclusive control over all the business and administrative functions of the practice and essentially leave to the professional corporation, again, which is owned by one of their, employees or executives, the clinical decision making. So this sort of friendly PC workaround is the main way in which we've seen in the setting of physician practices, the erosion of CPOM ban, the way we've predominantly seen that evolution. And so that's where we stand today. And this contracting workaround is what a number of states have sought to address when looking to potentially enforce or reinforce these CPOM bans. And I'll just mention a few different aspects of this friendly PC arrangement here that I think are notable. They're listed here on the right-hand side. One is certain contracting arrangements worth highlighting. One is a stock transfer restriction agreement. Oftentimes, the management services organization will bind the professional corporation owner, the physician owner, and especially in the context where the physician owners are more contracting at an arm's length, so maybe they're not employed by the MSO, but they enter into a business arrangement. one way of exercising control from the MSO to the PC is through contracting to take over some control over how the physician's equity is handled upon some period of time or upon some sale of the business so that, again, the MSO can exercise some control over the ownership, who owns the physician practice. We oftentimes see various gag clauses or non-compete clauses enforced on the physicians of the practice as potentially another mechanism of control by the MSO. And then here we just listed a number of different ways, in addition to those I've mentioned before, that the MSO may start to exercise control over the practice. Again, evincing this kind of broader, this broader spirit of control of the medical practice that expands beyond just this narrower conception of clinical autonomy or clinical decision making. So making hiring and firing decisions, setting working schedules and staff levels, dictating patient volume, establishing clinical standards, billing and collection. Again, I want to emphasize that these things are not and don't purport to be an intrusion on, a differential diagnosis or clinical decision making in the practice. The question here again gets to the heart of the spirit of CPOM, which is again this idea that by law that physician practices are to be owned by physicians, because all these decisions, all these things we just mentioned here, deeply implicate the way that medical care is delivered and received by delivered by clinicians and received by patients. Next slide, please. So a few different reasons why, specific examples of why CPOM might be useful for states to pursue. One is just to clarify the scope and the presence of a CPOM ban. This varies across many different states. You all, of course, will be most familiar with Washington. Some states still just have this mostly in common law. Other states have medical board guidance that speaks a little bit to what maybe MSOs can and can't do. Other states really have nothing to say about it. So one is just clarifying the scope of CPOM and whether, for example, in statute, whether the requirement is that physician practices own a majority of whether licensed physicians own a majority of the medical practice or all the medical practice. Those are kind of the two flavors that we see. In Oregon, for example, the requirement is just majority ownership. Many other states, it's got to be exclusive ownership. So just clarifying that in law is one reason that states are looking to pass some legislation to make it clear kind of what the state of the CPOM ban is. Second, to really engage this issue or this question of the role of MSOs. This is, as I just mentioned for, somewhat exhaustively, the rise of the MSO is really important for understanding how corporate employment looks today. And any CPOM ban that is looking to be enforced and have real teeth is going to have to engage either through statute or the medical board or common law the role of MSOs and how much they are supposed to be providing a service to the physician practice, or whether they can be used to functionally become the controlling entity of the physician practice. And then also a reason why states are looking to update their CPOM band is to clarify and potentially expand what enforcement looks like, whether there could be a private right of action here, whether this is something the AG handles, whether this is something that the medical board handles. There's widespread recognition that CPOM bans haven't really been enforced, and passing legislation can begin to codify, potentially resource enforcement of these CPOM bans. Next slide, please. So this is a map that highlights a number of the bills that were introduced last session. Folks may recognize that Washington is not on here, which it sounds like is an error, but this should give a flavor to you all of the kind of rising interest in CPOM bans. As I've mentioned a number of times, Oregon actually passed its bill. California just passed a version of this bill actually, I think the last week or in the last 2 weeks, that departs in some substantial ways to Oregon's bill. Probably a topic for a separate conversation. It's a lighter version of CPOM enforcement, actually is largely just a codification of what's in their medical board guidance, but the legislature codified that medical board guidance specific to private equity ownership, in what is, again, I think another indication that there's renewed interest in CPOM. And then next slide, please. Okay, last slide here that hopefully will tie this all together and talk specifically about the features of Oregon's SB 951. And hopefully, if this is making some sense, this will be review of what I just discussed here. So the structure of the bill is best understood, I think, in three parts, substantively in two parts, and then the third being enforcement, which I'll touch on after this. So substantively, two main aspects of the bill. One is a set of per se prohibitions on MSOs. One, largely banning stock transfer restriction agreements, which I discussed earlier. Again, these are contracting arrangements that allow the MSO to functionally exercise some control over the physician owners of a medical practice. So those are largely, with a few exceptions, banned in Oregon's SB 951. It also bans non-competes and gag clauses. Those are unenforceable. And then it also bans what's known as, or what's being called, this dual compensation or dual ownership provision, which says that, or this dual compensation structure where physician owners of practice will often be on the payroll, often be employed by the MSO. The law says that the physician equity owners of the equity owners or individuals, physicians receiving compensation from the MSO can't cumulatively be majority physician owners of the medical practice. So, for example, the friendly PC model would be prohibited if it, again, in this example, in the traditional model where the physician is employed or compensated by the MSO and then installed as a PC owner, that would violate this ban on dual compensation in the SB 951, which again is trying to distinguish and restore the kind of principal agent relationship of the PC, of independent licensed physicians owning a practice and contracting with MSOs to provide a service, rather than the MSO employing physicians and installing them as the kind of paper owner of the medical practice. So those are the per se prohibitions. And then the law and then the law states that MSOs may not exercise ultimate decision-making authority over activities that affect clinical decisions or care quality, and then provides a non-exhaustive list of what that might mean for the medical practice. So ultimate decision-making authority, meaning the physician owners of the medical practice must make the decisions around personnel, work schedules, times with patients, diagnostic coding decisions, clinical standards, a lot of the indicia of control that I named earlier that are oftentimes taken under the control of the MSO. The law says those decisions actually must be made. They can be delegated, but they must be made by the independent physician owners of the practice, billing and collection, price setting, payer contracting, and negotiation. So again, this non-exhaustive list of various that's supposed to provide context and provide definition to what it means to have ultimate authority over these decisions, what it means to truly like own and control a medical practice, which again is the spirit of these laws that in statute say that licensed physicians must be the owners here. And then the main mechanism of enforcement is through the AG and through private right of action. This is CPOM is codified as an unfair business practice in Oregon, and therefore the main enforcement mechanism is going to be through the AG and private enforcement. There's also going to be some review prospectively through Oregon's merger review law. When it reviews transactions, it's going to assess whether a transaction violates any of the aspects of the CPOM ban, and if it does, on that basis, it would deny a transaction again, if it was determined to be contrary to now existing law. Okay, I think I am at time.
Thank you, Hayden, for that nice overview. I'm looking to see if there are some questions or comments from board members. Not seeing hands up. Jane's quiet in the corner. Staff has questions, yes.
Thank you, Hayden. That was excellent. I was just thinking about what you had noted with Oregon and kind of the connection between their transaction review and the corporate practice of medicine, and trying to think through how the state, Washington, for example, would become aware of these types of issues, and if the corporate practice of medicine would have to be harmonized with whatever type of transaction review the state is doing, so that we would be aware of these friendly MSO structures. I guess I was wondering if you had any recommendations about the amount of proactive oversight that is necessary to kind of capture some of these more creative structures that are done through contracting that you might that I don't think that you would be able to understand without doing some type of proactive contracting review.
Yeah, I think there's a couple different ways to address this. One is, as you mentioned, the merger review looking forward might give some visibility into particularly the per se restrictions if the state is reviewing contracting arrangements that might explicitly state, for example, that an MSO is taking exclusive control over X, Y, and Z, or that might have a stock transfer restriction agreement. That could be, again, if the state were rigorously reviewing transactions and demanding all of these contracting documents, those things might be able to be caught with transactions moving forward. That, however, is not, especially in these arrangements where there's not an explicit violation in contract of law, but there's these forms of kind of de facto control. This is where the AG enforcement and the private right of action really becomes essential, and this can be bolstered as much as the state wants to in terms of how much it incentivizes a private right of action and awards for a plaintiff. And here, it's possible to really incentivize the litigation on behalf of physicians if there is a scenario in which the MSO is exercising control in an impermissible way over the physicians. We've seen some of this arise in California actually recently against some private equity employers, some somewhat successful challenges of the MSO PC model. The third I'll mention, and I don't know if Washington has explored this at all, but there's increasing interest from states to just have ownership transparency. One of the aspects of these contracting workarounds is it's very difficult for researchers, for policymakers to have visibility into who actually owns medical practices. It's a quite basic question, but one that we really actually don't have good visibility into. A lot of the numbers that are thrown around are um, data cobbled together from various sources and are probably not the truest depiction of what's going on here. So states, again, I'm not sure where Washington is, but states it's fully within their authority to more closely track who owns their physician practices and what sort of contracting arrangements are they engaged in. And if that were a continual process that were in place where you had Secretary of State or the medical board or the transaction review authority, wherever it is, monitoring where, just like their facilities, who owns them and what sorts of contracting arrangements they're in, that would give, I think, ongoing visibility for a state into what the state of corporate ownership is and what is the state of these contracting arrangements between physician owners and MSOs.
Thank you so much. And just regarding the enforcement piece, noticing aggrieved employees and competitors, thinking of Oregon's expansion of the corporate practice of medicine, was there whistleblower protections, as though they both seem like they could be retaliated against in these scenarios. Is that a piece of this?
Yeah, that's a good question. I think there ultimately were, but I would have to double check where the statutory language landed on that.
Okay.
I know
Thank
that was a subject of drafting, and yeah, is a good question.
Thank you, Hayden.
So thanks, Hayden, for this. Couple of things. So in Washington, we don't have M&A approval. Our AG's office does pre-transaction review, although not explicitly transactions involving PE firms. It's that current law is limited to transactions between healthcare providers. But so I know there's been some discussion about that. And I'm thinking in terms of an initial review, do you see, as we watch these kinds of arrangements over years, do we see the MSO sort of incrementally taking on more and more authority so that a one-time review of an initial transaction may not be adequate? What do you think?
Yeah, I think you'll want more enforcement than a one-time review of the transaction, especially because there's widespread. If Washington were to pass a law like this, there would probably be many arrangements right now that are not in compliance with the law. Um, Again, if the idea here is to enforce the spirit of CPOM and require that physicians are actually owning their medical practices, there are probably tens, maybe hundreds of practices in Washington that are using the MSO-PC workaround to employ physicians. So, right, the just transaction authority would not be enough here.
Okay, thanks.
Thanks. Just checking for one more round of questions and then we should move on to our next topic. I'm not seeing any further hands, but thank you very much for joining us today, Hayden. That was a very helpful overview, and we'll look for more experience as Oregon is actually implementing this. So thank you and hope to see you again.
Awesome. Thanks so much for having me. And folks, please feel free to share my contact information. We provide a lot of technical assistance and advisement to states on CPOM and my team at Brown. So feel free to reach out and we can try to be helpful.
Great.
Thanks so much.
Thank you. Okay, seeing on our agenda, we're a few minutes late, but I think we're going to be fine. We're moved to tab 9, which has an overview of the draft legislative report. And I think that Ross, Harrison, and Jen are going to walk through some of those highlights.
Thank you, Michelle. Yes, Cost Board staff is going to walk Cost Board members, give a quick overview of the content of the draft Cost Board legislative report. We included the draft in the packet that was circulated this week, but acknowledged that there was not an incredible amount of time to review that. So understand if there's not a ton of comments today, would welcome them if they are there, but are hoping that this overview gives you a good idea of the direction of the report and puts you in a position this weekend. If you have the opportunity to cozy up and read it, hopefully this will give you the necessary background. And just a few high points. Staff intended to try and make this report slightly shorter than previous year's versions, with the thinking that legislative members are incredibly busy and wanting to just focus their attention on the highest point issues So that was one of our goals here. Another goal was to avoid summarizing sort of just what occurred at the meetings, but really focusing on those areas that we are making recommendations on either for 2025 or 2026, and providing sufficient background that members would be able to understand why the cost board's focusing on that issue and making the recommendation. So would love any feedback that folks have on those areas as we go into this. So I will now hand it over to Harrison to start the overview.
All right, next slide, please. So I'll walk us through first couple of slides and then hand it off to Jen. So the report opens by reporting on some preliminary data on healthcare expenditure growth from the 2022 to 2023 data call, and contextualizing this growth rate and what it means based on discussions the board has had and related work within the state. The report also includes some other preliminary data that will be presented in more detail at next month's public hearing on the performance against the benchmark. So in 2023, as we can see in this graph here, total healthcare expenditures in the state increased by 6.2%. Set alongside other relevant measures, we see that this increase has outpaced the average Washingtonian's ability to afford care, essentially in the form of wages, growth in the state economy, as shown by GDP growth, and inflation. So taken together, this essentially is showing us that these high-level indicators are suggesting that there's an affordability problem in Washington that continues to worsen. Next slide, please. And for the second year in a row, we measured this growth and compared it to a benchmark value that's set by the board. Essentially, this benchmark that we talked about a little bit earlier and we're all familiar with is an aggregate indicator, again, for affordability. And for the second year in a row, statewide total healthcare expenditures exceeded that benchmark. So in 2022 and 2023, that benchmark rate was 3.2% each year. And in 2022, the total healthcare spending growth was 3.4%. This year's rate of 6.2% was substantially higher and was actually the second highest rate since we began measuring in 2017. Next slide, and I'll pass it over to Jen.
Thanks, Harrison. Just some additional context. So increasing healthcare spending is a national problem, and one example of that is that we see in other states that have cost growth benchmarks. They also have exceeded the benchmark this year. Healthcare continues to be unaffordable for many Washingtonians, and in the Ledge report, results of consumer surveys are cited as one way to illustrate that. Federal policies will negatively impact affordability in Washington, which we've heard from other agency reports over the last couple of months. And the low-income households, which are already in a precarious financial situation, will be among the most impacted. Next slide, please. You saw this graphic, I think, at the last meeting, which depicts the different areas of the cost board's areas of focus, and essentially together representing a multifaceted approach to working to try to control cost growth. The cost board's role moving forward will be to continue to monitor the impacts and remain open to creative and emerging strategies to address them, and ensuring that the state doesn't lose sight of the affordability challenges as attention will be drawn also to Medicaid and individual market changes, and just highlighting that the cost board's mission remains as important as ever. Next slide, please. And then looking ahead, the cost board will continue to monitor key data efforts and to support key affordability concepts to tackle priority policy areas that were originally identified in 2024. So at the high level, these are three areas that we saw in the Ledge report from last year, and where there was also some policy action and bills that were passed this year in 2025, and where we also continue to see work happening next year. So those are enhancing market transparency and oversight, slowing spending growth, and increasing primary care utilization. And I'll turn it over to Voss to provide more info.
Thank you, Jen and Harrison. Next slide, please, Audrey. Thank you. So this was our attempt to try and lay out what we describe in the report are kind of the three main priorities that we're looking at heading into 2026 and was also touched upon through 2025. In our report is roughly structured around these three priorities, and just wanted to try and provide a visual to help orient you when you're looking at the report. The first bucket that we discuss is related to market oversight and transparency following on the corporate practice of medicine discussions that we had. There's a couple pieces of legislation that passed during the 2025 session that fit into the market oversight and that we're very interested in working with the implementing agencies and providing routine updates. You see the provider registry, the state health plan, and restricting the corporate practice of medicine, which again is a bill that will likely be considered in the next legislative session. So wanting to prioritize broadly market oversight, but more specifically ownership transparency, two different potential policy actions related to transaction review, corporate practice of medicine, as well as maybe a stretch assignment of identifying the current gaps that we have in our transaction review here in Washington State. And that could be something that is brought to the board for consideration of different policy strategies to address those. And then on the more regulatory side, restrict anti-competitive contracting, as well as the state health plan update, which we've been fortunate to get routine updates on from Mandy Starr at OFM and continue to partner with them on those efforts to get the state health plan updated. The second bucket of policy priorities was slowing spending growth. Again, recognizing this is quite a broad category. But the first focus area was transparency, and another piece of legislation that passed last year, hospital price transparency, that puts into state law requirements related to hospitals publicly posting prices. Limiting price growth, that was HCA's agency-sponsored legislation from last year related to the PEB-SEB products. And so we will be continuing to monitor that. Again, that is implemented in 2027 and will continue to provide updates and also hopefully be able to measure those outcomes in the next few years once that's implemented. And then understanding cost drivers. This is a goal for us this year as well, to be able to, with our data partners within the agency, to take questions or issue areas that the board identifies from the benchmark data call results, which we briefly showed today, and then we'll give a full presentation at the public hearing on November 20th. The cost driver, the idea being that it allows us to dig a layer deeper and really analyze for a particular issue what might have been a contributor to those costs. And so really excited to lean into that opportunity, hopefully over the next year. The final bucket, primary care, specialty care focus, similar to the discussion that Judy led with us today regarding the Primary Care Advisory Committee's recommendations. I think there's a lot of different components that we'd like to touch on this year with the cost board's approval and interest, but some of those being report utilization, similar to what is being done at the OIC about consolidating primary care spending into one report so that we can have a better understanding of that information, as well as the other recommendations that came out of the Primary Care Advisory Committee's recommendations that we hope to support in advance throughout the year at the cost board level. And if you would go to the next slide, please. I also just wanted to give a quick explanation of sort of the timeline and next steps regarding the report and feedback. As noted on this graph, the draft went out for public comment on October 23rd, and we are taking written comments on that initial draft until November 3rd. We will do our best to incorporate the feedback received to then circulate the final draft of the legislative report on November 6th, 2 weeks in advance of our public hearing on November 20th. And of course, folks can submit public comment on any of those materials for the public hearing, including the report. The intent is to take a vote at the November 20th public hearing to approve the report. And so just to give a high-level overview, with the goal of submitting the report in December to the legislature. And so with that, I just wanted to open it up to any questions about what we presented or any feedback that folks, cost board members had related to the legislative report.
Thank you, Ross, Harrison, and Jen. I'm looking for hands in case there's any questions from board members. I think it's early. It was an introduction to the report, and there will be more comments. I see Leah has her hand up.
Yeah, Leah, please go ahead.
Thank you. I just really wanted to compliment you and the team on the report. I really appreciate the streamlined view, and I think others will too. And I think it's pretty comprehensive and provides some good information. So we'll give it some additional look and provide you with any feedback we have. But overall, it's really well done. Thank you.
Thank you. That's great to hear. Thank you, Leah. Bianca, please go ahead.
Yeah, I appreciate having this framework and thinking about kind of what the approach will be next year. I'm just noting and just reflecting on the conversations that I've heard over the course of this year that I certainly feel that a lot of our healthcare colleagues' leadership is feeling a lot of pressures that feel very like it's all about cuts and that they're struggling in this period of time. And I'm just noting that, especially on the left-hand side of the framework under the strategies for enhanced transparency and slowing spending growth, that we don't give a lot of maybe time to help our healthcare leaders think about how to also be supported during this time or what they could be doing, maybe helping them find some solutions. It does maybe kind of add on a little bit to the sense of being punitive. I'm not so sure what the right answer is here, but I just feel like I have heard folks say over the past year the sense of like, they could use some help understanding also where they can try to cut or do better. I do hear a general intent to want to do better and want to be in it together. I think in the primary care side, we're certainly giving more of that sense of support to the primary care. I'm just wondering, I'm not so sure where it would fit. Maybe it's under the strategy of slowing spending growth is that we also, maybe it's part of understanding cost drivers. Maybe it's identifying strategies to make that happen, like in a way that is solution oriented. I'm not so sure what the solutions are. I'm just feeling the sense of, I think folks could probably use some help to figure out how they get there with the cost spending challenges.
No, thank you so much, Bianca. That is a great comment. And does that speak to potentially bringing in more providers to meetings to kind of have some reflections on the challenges that they're facing and what type of gaps or ways that they could be helpful in supporting healthcare affordability? Is that sort of what you're thinking, Bianca?
Yeah, I think that would be helpful. I do think there's a tendency to kind of point to somebody else as probably the problem. So I think just understanding maybe and unpacking the issues in an organization about like what are they specifically struggling with, rather than assigning where the problem may be coming from, but maybe more ideally hearing from those who may be doing it successfully. Because I do think in the benchmarking activity, we have identified some groups that may be doing things better. We may be looking across the country and hearing from folks who have had some success in maybe limiting their growth. Looking for folks like that might be useful to hear in this avenue so that we can also be more helpful in identifying what the approaches are to help, like what policies need to be in place to help those that are looking for ways to reduce their spending growth. I don't know if I'm really making much sense.
No, I love that. Yeah, ways that we can help practitioners support healthcare affordability. That's a great point, Bianca, and something that we can look at incorporating and thinking about over the next year. So thank you. Lois, please go ahead.
Along the lines of what Bianca was talking about, back when we very first started, had a gentleman that I think was like a trauma surgeon talk to us. And he talked about how the decisions of insurance providers led him to have urgent cases that cost thousands and thousands and thousands of more dollars to handle because they'd been rejected from having simple procedures when they initially went to the doctor. And so, that's the kind of thing I think we need more information on and preventing extreme costs about.
Thank you, Lo. I really appreciate that example too. That's really helpful. Thank you. Harrison, please go ahead.
I just wanted to chime in response to Bianca's comment. I do think that the cost driver analysis, which we've had in previous years, but certainly we'll be building on in future years, will help us dive sort of a level deeper than the benchmark has, right? The data call is very aggregated information, and that cost driver analysis and the different ways we can slice and dice things will, I think, allow us to start the conversation in a sort of a collaborative way and a way that's a lot more informed than we've been able to do in previous years. So definitely looking at that cost driver analysis as a way to build on previous work and allow us to sort of identify certain issues that we can work with providers and carriers on. Thanks.
Thank you, Harrison. And not seeing any other hands, I'm just going to take 1 minute just to thank the cost board staff, Harrison, Jen, Rochelle Bogue, for all of their work putting this legislative report together, many days and nights, and they did a really fantastic job. So just want to call them out and note a great deal of appreciation to them. And with that, I will yield back to Michelle.
Thank you, Ross. I'll echo my appreciation for the staff team and all the work you've done today to get that draft legislative report and the committee materials today, as well as the work you have in process for our November public hearing and the reveal of more in-depth benchmark performance. So all of that is underway. The team's been working hard and fast. It's a busy time of year. So thank you all for that. Again, you have opportunity to send your comments and observations about that draft report to the staff team at the mailbox. I know it was put in the chat by November 3rd, please, so that the team can quickly turn those around. The goal is to have that next draft out for the public hearing that is scheduled in November. As you may recall, it is a board meeting, but it is a slightly different structure as set up in statute that we will hear about our growth performance measurement and hear from different panels of participants that that are called out in statute as well. So we have those forming now, and we'll have some in-depth conversation as well as finalize this legislative report at that November meeting. So thank you for that. Then I think the staff have put some material in tab 10. Just a sneak peek, looking ahead into 2026, they have finalized the calendar for both the cost board meetings and the advisory committee meetings. So those are highlighted there. I don't know if those have actually been publicly filed or we just guess those have been publicly filed already with the code revisor's office. But if you have major heartburn or, significant conferences that we missed and planned around as we were also trying to accommodate our other 26 committees and boards in the agency, we have to juggle quite a few meetings to try and manage the chairs and meeting options. I know the staff accommodated the schedule to reflect requests they heard throughout this year. And I'm looking at Rochelle as I say this to say that the board meeting will be on Wednesday afternoons going forward and the committee's on Thursdays. But
yes,
Michelle,
Yes.
the question I had was, I thought on the the advisory committee and the data committee that we were going to at least have a few of those that were split.
Yes, I'll let Ross speak to that.
Yeah, thank you, Eileen. That is certainly our goal. At this point, we're hoping to identify the appropriate topics to figure out how to split those two meetings. And currently, how we're envisioning it is we would hopefully cancel. For example, you'll see that data issues and stakeholder committees have the same meeting times right now. That we would cancel either the stakeholder or the data issues. And then have a more data specific meeting and then a more stakeholder specific meeting. But we are still trying to identify the appropriate topics to be able to separate those two meetings. So that is the goal, but we have not been able to, we have not yet solidified those topics. So just wanted to present the full calendar at this point, as any of these dates may be viable dates for advisory committee meetings for data issues and stakeholder. I hope that made sense.
Now, I just wanted to make sure we hadn't lost that. That was the feedback that we had gotten, so I wanted to make sure that didn't get lost. So, okay.
No, thank you, Eileen.
Leah, I also want to call out, we haven't checked the exchange board schedule for 2026. And I know that several of us were in board meetings this morning with the exchange board, and having them all in the same day is a challenge. So if you wouldn't mind checking, I don't think that they overlap since they're on Wednesdays now, but if you would let us know, that'd be great.
Will do. I was just making a note. Thank you.
Thank you. All righty. What else am I missing?
We just have two different views for the meeting dates for next year. This one's the one pager to see all of the meetings on at a quick glance for 2026. Great. So this one shows the calendar view, and you can see red is the holidays, and then the peach color is all the class board meetings, and then the orange is
I can't really hear what's happening in the room.
Sorry. I thought it was on.
Okay, this one right here is the year at a glance. So you can see just at a quick view all of the different meetings that we have scheduled. The red highlights are holidays. So we were trying to schedule around that, as well as the other the other board meetings that we have here at HCA. So the cost board meetings, we were trying to keep the same cadence. So every time that the cost board does meet, whatever month that is, you could see it's the fourth Wednesday, just to keep it consistent. And then the advisory committees always fall on a Thursday. And then the only one that is different, you'll see, is the November 18th meeting, which is the public hearing.
I think that responds a little bit to Bianca's question in the chat. Yes, we do have another board meeting on November 20th. We have labeled it as a public hearing because in the statute for the board, it is a slightly different makeup with different requirements. So it is a meeting of the board, but it is a public hearing with different format and different panels of speakers outlined in statute, and different timelines for materials to be available. Again, that's all mostly focused on the benchmark performance and that reporting. So the more detailed growth experience, you will get that in November.
And then for anybody interested in volunteering to serve on the nominating committee meeting, taking Carol's place, that is the bright green meetings. That's what we have scheduled so far. But like we mentioned earlier, it's also on an as-need basis.
Cool. Thank you for that plug, Rochelle. So again, if we have a volunteer for that, let us know, or we'll come begging shortly. With that, I think we have had a full board meeting with a nice array of topics. I thank you all for your time and attention. I know it was a long time to stay in a board meeting today. Appreciate your engagement as well as the participation throughout the whole year. It's really helpful to have enthusiastic participation in trying to manage affordability for our residents in Washington State. And we know we're facing some tough times ahead. So we'll talk about that more in the next meeting. What else am I supposed to say? Oh, the recording and the summary of this meeting will be posted shortly on the website. And again, we'll see you on November 20th for the public hearing. And then the next 2026 board meeting is January 28th. So, let us know if you have any questions or concerns, and we look forward to seeing you again next time. Thank you.
Thank you.